segment of photoreceptor, the interdigitation zone. This is a hyperreflective layer between the RP and the ISOS, the ellipsoid zone. Then comes the RP Brooks membrane complex and then the choriocapillaries. Now, vitreous OCT signs. Inflammation affecting the posterior segment of the eye leads to inflammatory cells infiltrating the vitreous body and a protein-rich inflammatory exudate into the vitreous, resulting in haze. The resolution of current OCT scanners cannot distinguish nanoscale single cells, but clumps of cells with inflammatory exudate are visible on OCT B scan as punctate spots floating in the posterior vitreous. Kane et al. Measure the OCT signal intensity of the posterior vitreous. Effectively, the signal noise coming from this part of the B scan image relative to the RP intensity. This correlates to a vitreous haze score. Now the VRI, vitreous RP relative intensity score, can now be measured in an automated fashion and has been shown to correlate with disease activity and resolution. This is the image showing vitreous haze, the posterior vitreous in the figure A. With treatment, this vitreous haze is decreasing in the figure B, and more resolution after prolonged treatment in figure C. Posterior hyaloid phase deposits. Hyperreflective pre-retinal oval deposits were reported on spectral domain OCT images in a series of patients with active toxoplasmic chorioretinitis. These deposits were located both adjacent and far away from active lesions. The deposits become smaller, entered the retina and disappeared with time until complete resolution, leaving no scar. The oval deposits were located not only on the surface of the retina, but also along the detached posterior hyaloid. As you can see in this image, these are the oval deposits at the surface of the retina and also at the detached surface of the hyaloid, which with resolution, they go into the retina.
One characteristic of this thing is that, they are like mirror images. So why they kind of hypothesize that these are inflammatory, deposits is that when the vitreous is attached, then these will be like one structure. But as the vitreous detaches, a mirror image or a mirror part of that inflammatory deposit will, go with the, detaching vitreous. So
Yes.
that is why like almost like mirror images on the, detached hyaloid face. And these are thought to be T cells, basically T inflammatory cells.
Yes, sir, T lymphocytes.
Please go.
Syphilitic retinal precipitates. Two main forms of syphilitic retinochoroiditis is confluent and plecoid. Areas of confluent retinochoroiditis secondary to syphilis present as triangular lesion with a ground glass appearance that differentiate them from the denser foci of herpetic necrotizing retinitis. They can be associated with superficial pre-retinal precipitates detected clinically as creamy white dots. OCT shows these as hyperreflective round foci on the surface of the retina that can migrate over inflamed retina.
Sorry to interrupt you here, Weber. Just wanted to ask other changes of toxoplasma which have been, told in this article. Will
Yes,
you be
sir.
later?
Yes, sir. In the end, sir, we have a case of which we have seen.
Sure. Go ahead. So we are right now on these, pre-retinal exudates, so that's what you're describing in the various conditions.
Yes, sir.
Sure. Great.
The plecoid form of syphilitic retinochoroiditis is present with an active, non-elevated plecoid yellowish outer retinal lesion involving the macula. SD-OCT image shows SRF, disruption of the EZ junction, and irregular or granular hyperreflectivity of the RP, but without elevation. Small clumps of photoreceptor and or RP debris are present within the detachment spaces. In this, we can see in the confluent this ground glass appearance, triangular and a ground glass appearance. And this hyperreflective dot we can see over the retina, which with resolution, it comes to the retina. This is the plecoid form, which shows in the first scan, the SRF, the RP granularity with treatment with penicillin After 7 days, this granularity, the SRF resolves, and granularity also resolves with time. Candida preretinal lesions. Candida species enter the eye either from the choroidal or the retinal vasculature and then head towards the vitreous to grow. The colonies appear
So,
as
Vaibhav, I had
yes,
a
sir.
question.
Yes,
How
sir.
do you create these syphilitic, these exudates on in syphilitic chorioretinitis from those which you described earlier with toxoplasma?
Yes, sir.
How do you differentiate the syphilitic, these lesions from how do you differentiate it from the toxoplasma chorioretinitis?
The toxoplasma would have a hyperreflectivity in the retina with a thickened choroid.
Right. Yeah. So if you see that you will come to, I think, later, but
Yes, sir.
just of these, the deposits, how will you differentiate? So basically in syphilis, they'll migrate over the inflamed retina.
Okay, sir. Yes, sir.
So, so they will be lying in proximity to the inflamed retina, whereas in toxo, that is not a must. So when
Yes,
you
sir.
find the exudates or clumps, over inflamed retina in proximity to the inflamed retina, then, it happens more in, syphilis. Whereas in
Okay,
toxo,
sir.
even if the lesion is, in the, in not in the at the posterior pole, but you will notice these changes at the posterior pole where the vitreous is detaching, so it will be
Okay,
away
sir.
from the area of, retinochoroiditis, whereas in syphilis, it will be overlying
Over
the,
the inflamed. Yes, sir.
that is the difference. Go ahead.
Yes. Candida preretinal lesions. Candida species enter the eye either from the choroidal or the retinal vasculature and then head towards the vitreous to grow. The colonies appear as whitish, hyperreflective, round-shaped lesions with homogeneous content laying on the retinal surface or growing into the vitreous body. Their high reflectivity generates a shadow on the underlying structures. The combination of the whitish lesion and the underlying shadow suggested the name of rain cloud sign, which we can see in this image. Hyperreflective lesion and then shadowing. Peripapillary OCT signs in posterior uveitis. It can be due to a solid lesion or to inflammatory swelling during neuroretinitis. In patients with sarcoidosis, the involvement of the optic nerve head by granulomas leads to a raised disc with hemorrhages. They have focal leakage on fluorescein angiography. The granulomatous tissue is highly reflective on OCT and is usually nodular. As the swelling of optic nerve head secondary to inflammatory cytokines or papillitis is often accompanied by fluid tracking from the nerve to the fovea, leading to neuroretinitis. On fluorescein angiography, the disc is hot with diffuse leakage. Presence of SRF and IRF adjacent to the optic nerve head on OCT is more common than in granulomatous infiltration of the disc. Further, a typical pattern of inner retinal folds due to mechanical forces of the macular edema can be seen. In contrast to papillitis, the OCT characteristics of these infiltrative lesions can be more severe with very swollen hemorrhagic optic disc.
Do you have the
Peripap-
pictures corresponding to the descriptions? I mean, do you have the pictures?
yes, sir. Yes, sir.
So, in this, if you went through the article, what has happened is that for this figure,
Yes,
the
sir.
legends have been, actually, they are like for the top figures, the legends are given as D, E, and F by mistake, I think. So,
Yes, sir.
the bottom one, actually, what you described in your first slide for sarcoid disc
Yes,
granuloma,
sir. Granuloma. Yes, sir.
you can
Is
see
inferior.
modular elevations in D. D is basically the sarcoid disc.
Yes,
Okay.
sir. Yes, sir.
And these granulomas are localized, and there may be some hemorrhages, like you can see at the inferior pole of the disc.
Yes,
And
sir.
angiography, you will get focal leakage, not a diffuse hot disc, right?
Yes, sir. Yes,
And
sir.
in F, you can see that the nodular hyperreflectivity, corresponding to those granulomas because of sarcoid, you can see in the area of the optic nerve head.
Yes, sir.
In the top A, B, and C is actually a papillitis and a neuroretinitis, associated neuroretinitis, which they are showing, in which they are showing gross, edema of the optic nerve with, adjacent neurosensory detachment. So in B, you have a hot disc
Yes,
corresponding
sir.
to the intense papillitis, which is basically because of the cytokines, and
Yes,
in
sir.
C, you are getting, a neurosensory detachment, which is involving the fovea.
Phobia. Yes, sir.
Also, what he said was that there are folds in the inner retina. You can see some, like fine undulations in the inner retina on OCT, which is corresponding to the area of neurosensory detachment due to neuroretinitis. Okay. So this
Yes.
picture is for the first two slides of the peripapillary changes that you talked about. Okay.
Yes, sir. Yes, sir.
Now, just before this, there's another slide which you were showing. I think you can go back to that slide.
Yes, sir.
Go, go ahead.
Peripapillary intraretinal fluid as subretinal fluid, retinal thickening with hyperreflective dots, suggesting an inflammatory cellular infiltrate and choroidal thickening. The core of larger granulomatous lesion of the optic nerve may become hypoxic, leading to production of pro-angiogenic factors promoting the growth of new vessels feeding the granulomas. These vascularized lesions can be successfully treated adding anti-VEGF injections to the underlying therapy, and OCT can follow the lesion regression.
In fact, we know of from the new articles that have come that granulomas not only on the optic nerve head but also TB granulomas also.
Yes, sir. Yes, sir.
They've been shown to respond to anti-VEGF injection.
Anti-VEGF.
Also, intravitreal moxifloxacin has been used, by Manisha Agarwal and her group from Shroff Charitable Eye Hospital, where they have shown that these, in addition to ATT and steroids, even TB granulomas show good response to intravitreal anti-VEGF and intravitreal moxifloxacin.
Yes,
Please
sir.
go ahead.
Yes, sir. Now we'll talk about dengue foveolitis. Basically, dengue has two entities: dengue retinopathy and dengue maculopathy. Dengue retinopathy, we see hemorrhages, rot spot, and whereas in dengue maculopathy, we have three different types of uh, dengue maculopathy. Type 1 is with diffuse retinal thickening centered around the fovea. Type 2 is with CME disrupting the photoreceptor layer. Type 3 is the foveolitis characterized by a yellow-orange characteristic lesion at the fovea that was later identified as an acute macular neuroretinopathy lesion. Basically, in AMN, there is deep capillary plexus ischemia, due to which the outer retina, the outer nuclear layer, and the outer plexiform layer gets disrupted. In the figure E, we can see deep capillary plexus ischemia. In figure B, we can see the affected layer of outer nuclear, outer plexiform layer. And after resolution, there is disruption of these layers, as you can see in figure C.
So the deep capillary plexus on OCTA is affected, in dengue, and and you can see that in the initial acute phase, the foveolitis, which is like a raised conical lesion, at the level of the outer retina, and in the foveal region, and this corresponds to a yellow-orange lesion in the fovea on color fundus, which is not very clear in this photograph, but we have seen better photographs of dengue foveolitis. And with the resolution, you can see that there is disruption in C at the same area where the acute foveolitis was, and some changes on the OCTA. Go ahead to the CME part now.
Cystoid macular edema. The central macular thickness is the most utilized quantitative parameter on OCT to measure and follow macular edema, but unfortunately not the best indicator and predictor for visual function. Rather, the amount of preserved central retinal tissue on OCT seems a good marker for visual function. Usually, uveitic macular edema presents as CME involving the central 1 mm and the inner 3 mm of the ETDRS grid. So basically, we have three circles: 1 mm, 3 mm, 6 mm. So basically, the 1 mm and 3 mm is affected in uveitic macular edema. The horizontal and vertical B scan shows a central, concentric, and symmetric CME, which is defined as cyst present foveally and parafoveally with homogeneous extension of the horizontal OCT cross-sectional scans. Also, the development and resolution of uveitic macular edema follows a distinct pattern. Characteristically, uveitic macular edema first emerges as small parafoveal inner nuclear layer cysts, which are followed by larger outer plexiform outer nuclear layer cysts. Finally, subretinal fluid may develop. Uveitic CME is reported to be prevalent in about 20 to 30% of uveitic patients seen at tertiary referral clinics and is the primary cause of vision decrease. Disorganization of the inner retinal layers, which was first described in DME, may be present in a minority of eyes and correlates with the worse visual function. Now, the outer retinal signs. VKH, subretinal membranous structures and RP folds can be seen in VKH. VKH is a bilateral panuveitis with multifocal serous retinal detachments. Those serous retinal detachments are delineated on SD-OCT by subretinal membranous structure that divide the subretinal fluid in two compartments. The submembranous space, that is optically empty, thus representing exudates from the choroidal vasculature through the breakdown of RP. The supramembranous fluid is mildly reflective, suggesting that there are more particles floating in it. The detection of RP folds or undulations on SD-OCT corresponding to the choroidal infiltration are a simple and effective biomarker of VKH. As we can see in this figure, figure B shows there is a membrane and there is supramembranous as shown by the yellow asterisk, and white shows submembranous fluid. The submembranous is a clear cavity, whereas the supramembranous has debris in it. And the figure D shows the RP indulation, which is a biomarker of VKH with SRF.
So what is the significance of these septae? So we also call them as septae in VKH,
Septae, yes.
which are kind of hallmark. What is the difference between the area marked with the white asterisks and the yellow asterisks? So you said they are the supramembranous and submembranous.
Yes, sir.
So what is the difference between them? What is the what have they kind of hypothesized based on this?
So basically, they say that there's a membrane developing just over the RP.
So the thing is
which
that
they mark. Yes, sir.
yeah. So why is there a difference? Like why is the area, the submembranous space totally equilucent, whereas in the yellow area, which is the supramembranous space, there is some debris, like you said, there is some signal. So what is the difference between the content and how do they explain that?
So in the supramembranous, the RP debris are there.
No. So basically what they have hypothesized, so we all know now, I think article, following this article, I mean, it's a few years since that article that we know that, there is what is we call as a bacillary layer detachment. Okay.
Yes.
So bacillary layer detachment, so for the past 2 years, this bacillary layer detachment has been described more and more. So bacillary layer detachment is actually a split in the outer retina between the inner photoreceptors and the outer photoreceptor layer.
Yes.
So this yellow area is actually it is between the outer and the inner photoreceptor layer. And that is why you have these, these may be part of the photoreceptors, bodies which have been stretched. So this is because of inflammation or bacillary layer detachment that we get this yellow space. Whereas the space marked by white is basically the submembranous. Basically, it is the retina is lifted off. So it's more like a neurosensory detachment, the white one. Okay. Whereas the yellow is more like a bacillary layer detachment, where there is a split in the outer retina between the inner photoreceptor layer and the outer photoreceptor layer.
Yes.
And then these undulations are again, commonly seen in VKH, what you see in D here.
Yes.
And on the left, in the C picture, obviously A is the wide field, ultra wide field picture of this VKH. But in the C, you can see these granulomas because of VKH, the hypocyanescent lesions that you see. In this, they are basically because of the granulomas, which we know are part and parcel of VKH. Please go ahead.
Neuroretinitis. Clustering of vitreous inflammatory cells adjacent to the optic nerve, so-called epipapillary infiltrates, in association with optic nerve head swelling, were reported to be pathognomic early OCT findings in neuroretinitis. They are found in association with the thickening of the RNFL in the peripapillary OCT ring scan. Further, a typical pattern of inner retinal folds due to mechanical forces of the macular edema can be seen. As we have discussed earlier, outwardly expanding concentric rings from the optic nerve head extending to the fovea. SRF and IRF are located in the outer plexiform layer and outer nuclear layer extending from the optic nerve head to the fovea points towards neuroretinitis. Retinal pigment epitheliitis. Acute focal inflammation and disruption at the interdigitation zone between the RP and cone outer segment interface. Outer nuclear layer swelling is there, disruption of the ELM and a dome-shaped appearance. During spontaneous recovery phase, this dome-shaped outer nuclear layer lesion decreases in height, then disappears. The ELM restores and the ellipsoid zone and finally the interdigitation zone. As we can see in this figure, the IZ and EZ disrupted. There is outer nuclear layer swelling, which resolves with treatment.
Right. So this RP epitheliitis or Krill's disease also has a good prognosis because as you can see with resolution, all the layers have been restored. So, we expect a good prognosis in this case. Okay.
Yes, sir.
Please go ahead.
Acute macular neuroretinopathy, as we've already discussed, it presents with sudden paracentral scotoma blood vision. There is a localized hyperreflectivity of the outer plexiform layer, Henle layer, and outer nuclear layer on OCT, as well as localized disruption of ellipsoid zone and interdigitation zone. Usually, the ELM is attenuated but still appreciable, and there is a petalloid appearance on NFAS OCT. Ellipsoid layer inflammation.
So recently, when we had the COVID pandemic, if you go back, AMN lesions have been described even in COVID patients. So
Yes, sir.
it's common to have, AMN lesions. They were, reported, I think, initially by the Brazilian group. And, so AMN is quite common after viral, infections also. Like you were showing, dengue, foveolitis,
Yes.
and also
Yes.
the AMN lesion, the foveolitis. So after viral, infections, AMN is quite common, even after COVID. Please go ahead.
Ellipsoid layer inflammation. Acute multifocal placoid pigment retinopathy is characterized by yellow-white placoid lesions, better highlighted with ICGA that shows patchy ischemia of the choriocapillaries underlying the lesion. Disruption of the EZ and IZ is accompanied by overlying hyperreflectivity of the outer retinal layers on OCT. SRF may be present with small areas of RP proliferation. As you can see in this figure, there is RP hypertrophy in the figure D, and there is outer retinal layer hyperreflectivity shown in figure C. Figure A shows placoid lesions, multiple placoid lesions.
Yeah, so in B, corresponding to the placoid, multiple placoid lesions, and on ICG, you can see the hyposynuscent lesions. Yeah, so those are much more numerous than what you would see, in the FFA, right?
Yes.
And they are very distinctly seen. And then the OCT changes which you were showing, the outer retinal changes are seen in C and D. Okay.
Yes.
Okay, go ahead.
Multifocal choroiditis. The multifocal lesions are of different age, with newer lesions whitish and older lesions are pigmented. This is reflected in the hypofluorescent appearance of the lesion in ICGA. The younger multifocal choroiditis chororetinal lesions are usually conical on OCT and show RP elevation due to isohyperreflective material. As the lesion evolved, they seem to rupture the Brooks membrane. As you can see in figure F, these are hypofluorescent in ICGA. Then there are iso or hyperreflective membranes in the outer retinal in the G and H.
Yeah. So how it is different from the other conditions is that there are areas with of different ages, like they said. So there will
Yes,
be evolving lesions. So initially it is like more like a conical one. So some of these you can see are conical, whereas other are broader. So
yes, sir.
they are conical, but then they kind of become more bigger in size and more like a disc shaped lesions rather than conical lesions. So that is, and you can see lesions of all ages, different kind of ages in this OCT picture.
Yes, sir.
And again ICG showing those lesions of MS.
Hyposin. Yes, sir.
Go ahead.
Now we'll talk about Azure, the acute zonal occult outer retinopathy, which has a very faint appearance on clinical exam and fundus photo. Basically, it has a trizonal pattern which is visible on autofluorescence and OCT. Zone 1 resembles the healthy retina with intact RP and photoreceptor layer. Zone 2 is the demarcation line, the transition zone between the healthy and the fully diseased retina, visible as attenuation of EZ and ELM, incipient thinning of the outer nuclear layer. Zone 3 describes the fully diseased retina with complete loss of photoreceptors layer, significant thinning or loss of the outer nuclear layer, and RP and choroidal atrophy. As you can see in this image, where the fundus photo doesn't show much, but as we go on the autofluorescence, there we can see a hyperautofluorescent lesion. And the OCT, we can see the photoreceptor disruption, the EZ disruption, and choroidal atrophy. Basically, this is the transition zone from the normal retina to the diseased retina.
So in the figure K, which is a section through the fovea, right?
Yes,
It
sir.
is corresponding to the yellow line in the fundus photo on top, right? So
Yes,
you
sir.
can see that there are three zones. In the foveal area, it's normal, right?
Yes,
And
sir.
then, as you approach the hyperautofluorescent lesion, which is around the nerve, you will start seeing some changes, right? Exactly where you're
Yes,
pointing.
sir.
There will be thinning of the outer retina, and also there is a distortion of those layers. And if you go further towards the nerve, there's total loss of the outer retinal layers. So
Yes,
these are the three zones. That is why there's a trizonal appearance of the OCT and also in the fundus
out
auto.
of yes, sir.
And these, the K and L, correspond to these areas. The L is actually showing it is below the fovea. So in that
Yes,
you see that mostly it is through again there are different areas seen in this, but it is not going through the fovea. So it is just below the fovea, the section
yes,
A. But again it is showing those changes of outer retinal thinning and distortion seen in azure.
yes, sir.
Good.
Now we'll move to multiple evanescent white dot syndrome. Basically, it has two patterns: ellipsoid spots and outer nuclear layer dots. In fast scan segmented at the level of outer nuclear layer shows multiple hyperreflective dots, lesion that could not be detected on fundus examination. The hyperreflective outer nuclear layer dots tend to form linear extensions from the external limiting membrane to the outer plexiform layer. The, the ENFAS OCT segment at the level of ellipsoid shows hyporeflective spots. The OCT through the spot shows attenuation of the ellipsoid band corresponding to the spots and hypertrophy of the underlying RP. The ICGA shows hypofluorescent lesion that co-localize with hyporeflective spots detected with ENFAS OCT segmentation of the ellipsoid. In this, we can see ellipsoid spots and the outer nuclear dots. The ellipsoid spots on ICGA shows hypocynescence, which is corresponding to these spots in the ellipsoid layer. And the figure D, it shows disruption of the ellipsoid and the hypertrophy of RPE. In the outer nuclear layer dots, we can see in the image E, they are very faintly seen on fundus photograph. But on NFAS, they can be hyperreflective, seen And these dots, they go from photoreceptor layer to the outer nuclear layer, as you can see here.
So these vertical extensions that you showed just now,
Yes, sir. Yes, sir.
so what do they signify, or what are they, standing for? And I think the next slide that you're covering is the PVRL.
Yes,
So
sir.
are there any similar findings in PVRL which you're going to show in the pictures in PVRL? Can you just go to like the PVRL picture? So can you
Yes,
see,
sir.
like in figure C, these things marked by this arrow?
Yes, sir. Yes, sir.
Can you see it? These by.
Truly, yes, sir.
Yeah, so these are very similar to what you were describing in Mudes. If you go back, to the slide prior to this, so in this you can see. So these are quite similar. I found, so that was quite.
Yes, sir.
Go ahead, please go ahead.
PVRL. In this, we see subretinal, mid, or hyperreflective material. Patients with PVRL often show hyperreflective alterations within the retinal layers at the level of outer retina and the middle inner retina, and a certain granularity of the junction between the photoreceptors and the RPE. A recently described finding in eyes with PVRL consists of hyperreflective vertical lines crossing the retina, as sir was mentioning. These are the hyperreflective lines
For the
passing
benefit of
through the.
anterior segment surgeons who are here, can you just tell what PVRL is? I mean, we have to. Can you tell the full form of PVRL?
Yes, sir, it's primary vitreoretinal lymphoma.
Right. So in the figure A here, you can see these subretinal deposits were marked by the asterisks. And also in figure B, you can see that the RP is kind of irregular, and you
Yes,
can
sir.
deposits. And also these deposits arise from the from the outer retina also, and they project towards the RPE. If you can see the black arrowhead in the center, uh,
Yes.
this one. So these are, again, they have been described in PVRL. So you can see these deposits like white arrowheads, arising from the level at the level of the RPE, and the black arrowhead arising at the level of the outer retina, again projecting into the space there. And the underlying RP is quite granular, as is marked by the black arrows. These are all granular RP changes. And the latest change which has been shown in PVRL is in the center in C, which is these vertical lines which traverse the retina.
Yes.
Okay, so these are all basically lymphoma cells, which are growing here. And so as we all know that primary vitreoretinal lymphoma will commonly occupy the space between the Brooks and the RPE.
Yes.
And choroidal lymphoma, on the other hand, will grow in the choroid. So it will be at a deeper level. This is not a picture of choroidal lymphoma. So these are pictures from a primary vitreoretinal lymphoma. Please go ahead.
Now, we have two figures here, basically of choroidal granulomas. One on the left is of sarcoid granuloma, and one on the right is of tuberculoma. So the basic difference is, in tuberculoma, we see outer retinal hyperreflectivity and a large granuloma which involves whole of the choroid. And there can be RPE disruption also, which is called a contact sign. As we can see in these figures, this is outer retinal hyperreflectivity with a large granuloma. Clinically, tuberculoma are usually single, whereas sarcoid granulomas are multiple. Whereas in sarcoid granuloma, it involves a particular layer of choroid, not the whole choroid, and there is no outer retinal hyperreflectivity seen. There can be SRF seen, as you can see in the bottom. Yes, this one. SRF can be seen, but outer retinal hyperreflectivity is usually not seen in sarcoid granulomas.
And so you can make out the difference. And can you see, in the top left picture in the sarcoid granuloma, what is underneath that? So what has been described again in sarcoid granulomas? So there's an increased transmission there, underlying those granulomas in the top left.
Yes,
So
sir.
also been described in sarcoid granulomas and not in other kind of granulomas.
Yes, sir.
As you've rightly shown, in tubercular granulomas, which is the picture on the right, there is full involvement of full thickness of the choroid with total disruption, and also the outer retina commonly, that
Yes.
is called the contact sign. Whereas in the sarcoid, the lesions are mostly located within the choroid and the outer retina is spared. At the maximum, you may get some overlying subretinal fluid, but the outer retinal layers are fairly okay. That
Yes,
is
sir.
differentiate TB versus sarcoid choroidal granulomas. And obviously, TB granulomas are much larger in size and more, like solitary, whereas sarcoid granulomas are much more numerous
Yes, sir.
and smaller in size. Please go ahead.
Now I've taken up this toxoplasma retinochoroiditis in the end because here we have the figure from one of our own patient, who presented to us in November 21 with this kind of OCT, which shows a hyperreflective retina. As you can see, a hyperreflective retina, and there is underlying choroidal thickening, which cannot be seen in this figure, but there is choroidal thickening. And as we go on to treat the patient, and the patient comes after 1 month, we can see the hyperreflectivity and the moon goes down, and we can see the choroid now where it was not seen earlier. And the patient presented to us of late on 9th. Here you can see the choroidal layer and the hyperreflectivity has gone down. The lesion has come down with treatment.
So, so we can see, like, from if you compare the previous picture, that there is a mostly it's an inner retinal involvement. It's more a retinochoroiditis as opposed to a chorioretinitis.
Yes,
And
sir.
also, you can see in the vitreous those changes which you were describing initially,
Yes, sir.
deposits,
Outer.
which are getting pulled up into the hyaloid when the hyaloid is detaching. And there is beneath that, in the choroid, there is inflammation. So it is a retinochoroiditis. And with treatment from 10th November to 28th December, you can see the change, that the inflammation of the inner retina is resolving, and you can see the details of the inner retina much better in the figure on the right side, because the inflammation is becoming more localized and it's responding to the anti-toxo treatment which this patient was put on. And also, as the inflammation subsides, it we have also seen, you've shown in your earlier slides, that PVD is also induced sometimes. So you can
Yes,
see
sir.
PVD is being induced here actually, and later on even further separation of the vitreous from that area of inflammation. And
Yes.
again, this picture from just a few days back, you can see the inflammation is more localized. The level of the choroid, there is much lesser inflammation, and now it is getting more and more localized to a smaller area in the inner retina. And finally, this will resolve. So hopefully, next time when we follow up this patient, we will be seeing resolution of this area of focal retinochoroiditis due to toxoplasma.
Yes, sir.
Okay. So anything else? Yeah, thanks. So
Thank you.
any questions which are there? Anybody has any questions? Any comments, Dr. Das? Any comments from Dr. Shweta? So I think it was very difficult to actually. It's a very complex kind of. It's not a very simple, topic that was there in the journal club today. It was, it's quite specialized, and people are now getting more and more, focused on imaging. And this is only what you described today was mostly, on the, spectral domain OCT. And we have not really covered the choroidal aspect. You did, have the TV versus sarcoid thing there, but,
Yes.
there's a whole new, there was another review, I think, which I had shared with all of
Yes,
you,
sir.
which is on the choroidal aspect of imaging in posterior uveitis. Maybe, sometime later we can cover that topic as well.
Yes, sir.
So all these signs they help. Why they help is that, one, based on the OCT signs, the patient is spared all those invasive tests. And we do a battery of investigation, but you can customize those investigations better if you have a clue as to what condition you are looking at based on the biomarkers, the OCT biomarkers. And also, the authors of this paper, they suggest that, with the recognition of these OCT changes, it could also help in machine learning. And for AI, it may become a, important thing, because if these OCT biomarkers are recognized by machines and they can learn those, then it can be useful in making the diagnosis or based on machine learning and AI.
Yes.
So
Yes.
that is what they have suggested, that later on this can be an application of these recognition of these OCT findings.
I think it was a very good presentation. I'm sorry I joined late because I reached home from the circuit late. But Vaibhav, you presented well, and Dr. Saurabh explained so well. I enjoyed so many new things that I learned today. Very useful presentation.
Thank you, sir.
So Dr. Shweta, anything to add? Dr. Das, anything you want to add? Great. So I think on Friday, we will be having a class by the fellows where, they will be sharing their the research, publications that they are working on. So I look forward to attending that.
Yes, sir.
Yes, absolutely. I think it'll be very interesting, and we can all kind of chip in with what we think is the best way forward for all of us on the various publications that we are working on. It'll be nice. So thank you so much for today's session.
Thank you, sir.
Thanks, Vaibhav. Well
Thank
done.
you so much, sir. Thank you so much, sir.
Thank you all for joining in. Thank you.
Thank you, sir.
Okay.